from wherever you are in the world and joining the 5th World Sepsis Congress, Sepsis Research and Innovation. And if you've had a chance to attend to any of the sessions today, I'm sure you have been inspired. I'm Dr. Keith Martin. I'm the Executive Director of the Consortium of Universities for Global Health here in Washington, D.C. And we have a star-studded lineup of experts who are going to address one of the fundamental challenges, but absolutely vital challenges if we're going to reduce sepsis worldwide. And that is, how do we integrate emergency, critical, and operative care to be able to prevent, detect, and rapidly respond to this global killer that affects more than 50 million people a year, but also kills, tragically, 14 million people. I would like to thank Dr. Tex Kassoon, the president of the Global Health Alliance, Dr. Miriam Jashi, the CEO of the Global Health Alliance, Marvin Zick, the general manager, and their teams who really done an incredible job of putting this together. One little really fascinating bit of information, and a very positive one, is that more than 10,500 people around the world have so far attended the Congress. And tomorrow will be day 2. So if you can attend, please do. Also, all of the presentations will be posted online, will be shared globally. And so please do, once those presentations become online, please do share them with all of your networks so we can develop the critical mass to move forward. So without further ado, let me introduce the speakers we have today. Each speaker will make their presentations. There will be questions and answers for a period after each speaker, and then we'll come back for further Q&A and discussion. In total, the session will last 1 hour and 15 minutes. So please put your questions in the chat when you think of one, and we'll get to as many as we possibly can. So in the order which they will be speaking, first is Dr. Krista Bracke. Dr. Bracke is from the European Sepsis Alliance in Belgium. She'll be speaking on My Pathways for Sepsis Care. Next will be Dr. Tsion Firew. Dr. Firew is from the African Health Sciences University in Rwanda. She'll be speaking about integrated emergency, critical, and operative care to improve outcomes from sepsis, and also the World Health Assembly's Resolution 76.2. Next is Ingrid Laerdal. Ms. Laerdal is from the Laerdal Global Health in Norway, and I would like to thank her and the Laerdal family for their enduring support of addressing sepsis. They have been outstanding in supporting this effort. Ms. Laerdal will speak on the coordinated implementation to improve sepsis care through the Acute Care Action Network. Next will be Dr. Joe Bonney. Dr. Bonney is from the African Federation for Emergency Care in Ghana. Dr. Bonney will be speaking on scaling basic emergency care for timely resuscitation and sepsis. And finally, Dr. Carolina Haylock-Loor will be speaking on optimizing sepsis outcomes through enhanced recovery after surgery, and she is from the World Federation of Societies of Anesthesiologists in Honduras. So I'll start with Dr. Bracke. Dr. Bracke, thank you for joining us. Over to you, and please, if you have any presentation, please put your slides up. Over to you, Dr. Bracke.
Thank you very much for inviting me to share my experience on My Pathways for Sepsis Care. And I'm very honored that I am invited for this World Sepsis Congress. I used to work for the Belgian National Radio until I tumbled into a second life on January the 30th, 2009. It was really a close call. I thought I was fighting against flu, but instead I was infected by the Streptococcus pyogenes bacteria. It was a very quick negative evolution. Very soon there was multiple organ failure and I went into a septic shock. Several cardiac arrests followed and I needed to be reanimated several times. At one point there was less than 5% chance that I could survive, and if so, the intensivist couldn't say anymore what the damage would be. It could be physical, mental, because of the huge amount of noradrenaline they had to give me. After a time, it became clear that both my feet and my lower legs were necrotized, and they needed to be amputated. That was in the middle of March, and also both my hands were necrotized or partially necrotized. Especially the right hand needed a reconstruction, which lasted for about 9 hours. But afterwards, I had two functional hands again. The rehabilitation was a very long and hard period, and in a way, it never stops. At first point, I needed to start walking on prosthetic legs. That was at the beginning of June. It was overwhelming and weird at the same time because, at one point, I didn't know how to walk on prosthetic legs because I never had ones. But of course, the only thing I wanted to do was walk again after being in a wheelchair and lying in bed for several months. Now, before you put on your prosthetic socket, you have to roll off a liner on your stump. And in this liner, sweat heaps up, and this sweat might cause friction, wounds. It might lead to wounds, and then you might end up in a wheelchair again instead of using your prosthesis. And that's why I feel like a tightrope walker. I'm balancing between sitting in a wheelchair and being able to walk on prosthetic legs. During that horrible year, 2009, I also suffered from 10 pneumonias until I got the diagnosis of primary immune disorder. Apparently, I don't produce any IgG2 protein any longer, which should protect me against mucus encapsulating bacteria. And this primary immune disorder was the reason why this infection evolved so aggressive and so severe, and was so severe, and it was an even faster process than it usually is. But due to a weekly therapy with immunoglobulins, I got stronger and stronger, and I could starting to push my boundaries. I could start to try and swim again, to dance the Argentinian tango again without natural legs. I could try to run a bike, which was very important to me as I needed to bring our two small boys to school, and walking, for about 600 meters, that's the distance to school. That was even too far for me at the beginning because the pressure on my stumps was too high. But after a while, I got the opportunity to try and run on blades, running blades, like you might have heard from Oscar Pistorius. And this helps me very much in my daily functioning. And so I still run, nowadays for about 5 kilometers 3 times a week. And I also have been writing down my experience of how you changed or your life can change from one moment to another. I've been writing it down in a book which is published in Dutch and in French. It's called My Life on Stilts, à toutes jambes. Unfortunately, there's no English translation so far. Now, the curious thing is that sepsis was merely a footnote. It was mentioned in my file, but not mentioned to me. Now, of course, if both your feet, your lower legs are amputated, you have a lot of pneumonias, all this causes a huge impact. And some of the cognitive aspects you also notice, you just try and take them for granted and you try and live on. And it was only until September 21, when there was a round table for the Belgian Parliament organized at the occasion of World Sepsis Day, because there were some plans to try and install a national action plan on sepsis. It was only then, 12 years after the original infection, that I realized that some of these cognitive aspects, long-lasting aspects, were actually caused by the sepsis. Now, what were these long-lasting effects? Well, some extreme and unpredictable fatigue. Listening to somebody was really a challenge, which was very, a huge confrontation, knowing that I was working for the radio. I had to listen to people all day. Concentration problems, which limits me in driving a car, for example. There are too many impulses at the same time. Sometimes I have difficulties in finding the correct words, and my short-term memory really is disturbed. And we nowadays talk about long COVID, but I'm wondering, sepsis, of course, is a condition, one moment, one point in your life, but the consequences keep on lasting. So why can't we talk about long sepsis? Now, the question, how did I survive sepsis? I think that intuition played a key role in it as well. And it started with the alert reaction from the wife of our general practitioner. She got a phone call from my mother asking for a house visit. And she thought by herself, why isn't Mrs. Bracke calling herself? Maybe she isn't able to call anymore. So she alerted her husband, our general practitioner, and 5 minutes later he stood on our doorstep. So this feeling that something was really wrong was very important. Also, when I arrived at the emergency at the hospital, care professions there took the right decisions at the right time, like this cardiologist who gave me a broad spectrum antibiotics even before he had any scientific proof of this severe infection. And later on, the intensivist said that this action, this broad spectrum antibiotics, which he had given me, was really life-saving. And if he hadn't done so, maybe she couldn't have reanimated me any longer or anymore. So it's the so-called golden hour for a sepsis patient. And this combination of evidence-based medicine and lessons we might have learned from daily experience and giving some room or some possibility to using intuition itself is really life-saving in terms of sepsis care. I'm convinced of that. And there's actually a professor, Philip Haagdoorns from the University of Antwerp, who is doing some research on that topic as well, on the importance of intuition combined with evidence-based medicine. And I'd like to give you some take-home messages. I really think it's time we start working even harder on an action plan on a global level, an action plan for sepsis. We must really increase the overall awareness, knowing that about 80% of sepsis cases occur outside of hospital. It's very important, I think, if we keep on educating healthcare professionals, especially people working in primary care and on the emergency department. Way too often patients are not taken seriously and they're sent home with a painkiller. And when they arrive at the emergency department a day later, sometimes it's too late, unfortunately. I think campaigns to prevent infections are really important, because if we prevent infections, we might also be able to prevent sepsis. And it's important to invest in the rehabilitation for all patients, not only younger patients or elderly patients, as in some European countries is the case, and invest also in aftercare for long sepsis. And we should continue stimulating multidisciplinary research. I'm also convinced that test results only are not enough. These results must lead to prompt action. That means within 1 hour after diagnosis. And of course, once you have these results, you shouldn't keep them in your unit, in your test unit. The communication between these different units, the laboratory unit, the clinical professions, is so important. And well, of course, unfortunately, we all know already that anyone can get sepsis at any age. It's a matter of being extremely alert. So this concludes my take-home messages.
Krista, thank you very, very much for sharing your powerful personal story. Nothing can be as powerful as somebody who's been affected, and your powerful eloquence really speaks to anyone in the world, to the danger, but also the need and opportunity for addressing this challenge in the golden hour, to be aware of it, vigilant, introduce aggressive therapy, and in the importance of prevention as well as being able to treat and education. So you really captured an awful lot of very important messages, and you've started this off wonderfully. So just in the interest of time, because we want to give everybody a chance to make sure we don't run out of time, I'm going to go to the next speaker, but we'll get a chance at the end, hopefully, to respond to your questions. So next, it's a pleasure to speak to a good friend and a great global health practitioner, Dr. Tsion Firew. Tsion, wonderful to see you. Please, the floor is yours.
Great, thank you. So that was such a powerful presentation from Dr. Krista. Thank you so much for really sharing your personal, and I think nothing could be as powerful, and I think really kind of a segue to how what you went through personally and what you went through personally on a global scale level, and really how could we use the tools that are available to advocate for our patients and also to advocate at a higher level, such as the WHO and at a policy level. So Dr. Keith already introduced me. I'm the chair at Africa Science University, and I'm also an associate professor of emergency medicine in New York, which is where I am currently. I have no disclosures to make. And I think since this morning, we've listened to amazing presentations from researchers, educators, and also from policymakers such as Dr. Tedros and as such. So usually when I attend any sort of research and different presentations that applies to education, I look for the link between that and how that has affected policy, right? There are things that we do in our sepsis care, but how does that inform policymakers, and how does policy also change, or how does policy also inform our decision making day to day? And also, for people like maybe the participants list I've seen as people from all over the world, some places do have the resources to develop their own guidelines, but in many lower and middle income countries rely on resources from governing bodies or organizations like WHO. So I know Dr. Tedros came and spoke this morning, and many of you guys, I hope, know what WHO is and what it does. But I think kind of really talking about how health policies that affect sepsis care and how they're related to decision making that happens at WHO level, at the United Nations level. And I'll say this, when I was in academia and when I was really working on the research, until I started working as an advisor for the Ministry of Health, I did not know how that actually could be interlinked to our everyday work in sepsis care. So the UN, as many of you guys know, it is composed of 193 countries, which we call member states. And every year they meet at the United General Assembly in New York, and they gather to discuss multilateral discussion on international issues, including health, peace, and security. Sometimes there's high-level discussions such as AMR, universal health coverage, TB. This September is going to be on non-communicable diseases, actually delivers the action and priorities, and also affects the funding that are available. And the WHO, which is a specialized agency of the United Nations, and people think a separate entity, but they're not, as under the UN umbrella, focusing on international public health. So the WHO is one of the several specialized agencies on health under the UN system. So you might say, how does the UN really, what happens at UN and UNJ level affect our everyday policies and guidelines, especially when it comes to lower middle income countries, or what really all countries that gather this, what are the big overarching goals? So some of you guys might have heard what we call Sustainable Development Goals, which are a list of 17 goals that all countries are trying to achieve. And universal health coverage, or the item that really affects the health, is UHC3, which is SDG Goal 3, which is universal health coverage. And SDG 3 has 1 goal and 13 targets and over 25 indicators. So many of you guys might know what universal health coverage is, and I really did not understand it until much into my public health journey. Universal health coverage is pretty much trying to ensure that everyone can access the health services that are available, including prevention, treatment, and care, and it protects individuals from financial hardship by reducing out-of-pocket healthcare costs. UHE is trying to also promoting equity, making sure services are available. And the 2019 high-level discussion at the UN General Assembly was universal health coverage. And as of 2024, approximately 73 out of 195 countries have achieved universal health coverage, and many countries have not been able to progress towards universal health coverage due to the lack of resources. So part of the SDG goal, and I think the resolution that I'm going to talk about, which is the ECO's resolution on emergency, critical care, and operative care, which addresses many of the SDG targets. And as you would see in the next slide that I'm going to share, really many of the resolutions are under the umbrella of universal health coverage. And this is what we really use as part of our advocacy tool. And I really do hope that you take that. The resolutions and the policies here could be used as your advocacy tool to enhance sepsis care. So SDG targets here that I've listed are things that could be targeted by having an integrated and strong emergency critical care and operative care. And the ones that are highlighted in green are things that actually would like to believe that affects sepsis care. So really use this as part of your advocacy tools when you apply for your research grants, when you're also using it as the biggest umbrella of really achieving global health equity. And these are the things that I usually show as my advocacy tool for policymakers, for university level decision makers. So these are some of the resolutions that have come and gone. Unfortunately, this was one that we were involved in from the Ministry of Health of Ethiopia, but happened right before the pandemic. And really because of the distractions with the pandemic, many of this were not able to be achieved. And recently, the one that I'm going to talk about for the next 5 minutes is about the resolution that passed in May of 2023, which is informed by prior resolutions and applies for integrated emergency, critical care, and operative care for universal health coverage and protection from health emergencies. So you've heard our previous speaker about her personal experience, what she was given within the golden hours, how really the caretakers thought that it was probably one of the most life-saving intervention. And really what's listed under the ECOs is having this integrated and timely approach to any acute illnesses. So this impacts over half of all deaths in low-middle-income countries because people lack access to timely care. The ECO resolution helps governments to progress towards the 10 of the SDG targets that I sent you. And it's very important, are essential for preparedness for response to emergencies. We talk about, COVID. Recently, I was involved in the Marburg outbreak that happened in Rwanda, but really this timely care is at the center and at the center of the component of the resolution, and really affects sepsis care. So for the next 2 minutes, I'm going to go over these 5 slides. The resolution is a 6-page document, but I've selected things that could apply to how you can use it to advocate for sepsis care, and also how you can integrate it among other services within your hospital. So sepsis is a life-threatening condition that you guys all know. And early recognition requires rapid treatment and continuous monitoring across emergency, critical care, and operative care levels. And the key point from the resolution is advocates for seamless approach to care that is essential for sepsis management, ensuring timely intervention and reducing mortality. And I think what the underscoring in all this is the timeliness, which we really lack in many parts of the world. Struggling pre-hospital and hospital-based sepsis care, right? And we're in the US, where I practiced for 10 years. There's a 911 system. People can get care, can get fluids before even they get to the hospital, and sometimes even antibiotic, right? So the resolution really calls for this integrated approach, and also struggling pre-hospital services. And you can imagine if people could get care on the way to the hospital, right? How that could really change your outcome in sepsis care. And one of the other approaches, multidisciplinary coordination and teamwork for sepsis. We know that we can't work in silos, because if the patient doesn't get the necessary treatment, either at the pre-hospital level in the emergency department, and they just showed up to the ICU, and we don't work with our nurses and pharmacists, usually there's a bad outcome. So there is a cascade training that's suggested as part of the resolution that ensures that all teams are well prepared to handle sepsis effectively. And Dr. Joe Bonney is going to also cover some of the trainings that are available through WHO channels. The other thing is training and capacity building for sepsis recognition. I think we all know that once you have a group of nurses and first providers that actually are able to detect sepsis and act on it and manage it appropriately, could actually have a big impact on sepsis care. And the resolution outlines this as part of that. And the other thing is also monitoring data collection and quality improvement, right? If we don't know where we are, we don't know where we're going. And also as part of what Dr. Tedros had mentioned this morning, really the sepsis guidelines that could be available for many of us across the world. So part of the resolution really encourages and advocates for monitoring the quality of care that's provided, which directly supports sepsis outcome improvement. And some of the the tools that we use could be used for quality improvement, and also for resources to see how it could be improved. The last thing I would say is really, what we do every day in our hospital level cannot be encouraged or cannot be supported if it is not having the national level and regional action plan that's coordinated. And this is highlighted also in the resolution, and how it relates to our sepsis care is that it can be incorporated into the action plans, ensuring that governments prioritize sepsis management within their healthcare systems and allocate necessary outcomes. I would encourage everybody to look at the resolution, see how you could put it as your advocacy tool, whether you're trying to change guidelines within your hospital system or a national level. We usually say a health policy or guideline or resolution is only as effective as its implementation, and without action, it's just a word or a paper, an order on a paper or text on a website that nobody looks at. So I think all of us, I encourage all of you guys to be a tool, to be the change agent, and also to be able to use that and advocate for your patients in sepsis care. Thank you.
Tsion, thank you very much for a really outstanding presentation. You whipped through a very long and complicated list of resolutions. It's no easy task, and you synthesized it for all to understand. So really well done. That's fantastic. And thanks for focusing on the need for resolutions are, they're pieces of paper, but they're only as useful as they are implemented. And your cri de coeur, your call for all of us to be able to translate what's in those resolutions, and also to draw attention, I would say, to the amazing work at the WHO, Drs. Terry Reynolds and Dr. Lee Wallace, who are really doing an outstanding job at the WHO during a difficult time. They have really created, for everybody who's listening, please take a look at the WHO website. Look at the ECHO part of that, Emergency Critical Operative Care. There is a host of really valuable tools that you can use and implement in your own hospitals, in your regions, and more broadly. So those are practical tools to use. Take them and use them. So I think what we're going to do to our wonderful speakers is we're going to go through the speakers, and then we'll open it up and get to the questions. So Tsion, it's a fantastic presentation, and it's a nice segue into Ingrid's presentation. Ingrid Laerdal, the CEO of Laerdal Global Health, a real outstanding leader in the space, and have done an amazing job to really support the global action against sepsis. Ingrid, thank you for the efforts of you and your family to do this, and we'll turn it over to you. Welcome.
Yeah, perfect. Thank you for that. And thank you so much for the opportunity to speak today. I'm Ingrid Laerdal, and I represent Laerdal Global Health, but also the Laerdal Foundation, which is one of the co-founding partners of the Acute Care Action Network. So thank you, Tsion. We just heard you speak about the ECO resolution, Emergency Critical and Operative Care. And I'll speak about ACON, which is WHO's new Acute Care Action Network that has been established to answer the call of the ECO resolution and turn the big global goals into action. So ACON seeks to address the 30 million time-critical emergencies that happen every year. And that's actually every second death globally. And among these, as you see on the screen here, sepsis is by far the biggest burden of all these time-critical emergencies. But there are also other categories like cardiac arrest, stroke, trauma, and maternal and newborn that roughly have around 5 million deaths every year. And while these have typically been addressed in a siloed manner, they have a set of common denominators. And one thing, it's in the name, it's that timely response to these is critical to save lives. In a newborn resuscitation, you have the golden minute. In a cardiac arrest, maybe up to 10 minutes. In stroke, sepsis, there is talk about the golden hour. But time is of essence. Also, the majority of these cases happen in low and medium income countries, probably more than 90%. And also 80 to 90% start in the community. Maternal and newborn is a bit different because now most of the births happen in institutions, but for all the other categories, the majority starts in the community. So to be able to save more lives from these time-critical emergencies, it's critical to have a strong acute care system that spans all the way from the community and the layperson, the bystander, who understands the danger signs and activate the ambulance or first responder, or brings the patients into the hospital, and that there is quality care throughout the acute care system, from ambulance and into the hospital. So instead of the earlier siloed approach, there is a great potential for synergies and impact by a more coordinated approach to acute care systems across all these time-critical conditions. And that is what ACON is trying to do. So the COVID-19 pandemic also highlighted critical gaps in acute care preparedness, even in well-resourced settings. And strengthening acute care systems is critical. They play, first and foremost, a vital role, not only for meeting the day-to-day health needs, but also for health security and effective emergency response during outbreaks or natural disasters. They're also critical to achieve universal health coverage, and they are addressing the rising burden of disease. Acute conditions are already accounting for half of the deaths in low and medium income countries, and this burden is rising. So WHO launched the Acute Care Action Network to support countries and partners to build a stronger and more integrated acute care system. And since it was launched in 2023, more than 50 organizations have already joined the network, and it's growing day by day. And these organizations work across the full continuum of care. So they work from the community to the ambulance, EMS systems, to hospitals. And they also work across primary, emergency, critical, and operative care. The vision of ACON is simple, but it's also very ambitious. It's to save millions of lives by supporting acute care development globally. And this is being done through coordinated implementation of WHO's acute care resources. And I'll share a powerful example of one of the tools and how it can save lives from sepsis, and that's the basic emergency care program. So WHO conducted a 2-year study across 17 hospitals in 3 countries in Africa and Asia. And the study followed 35,000 patients admitted with one of these acute conditions, and 2 of them are very closely associated with sepsis. So after implementing the basic emergency care course, together with a few low-cost improvements in emergency units, the results were striking. They saw a significant reduction in in-hospital mortality across all the studied conditions. And for pneumonia and diarrhea, which are particularly closely related to sepsis, there was a 44% reduction and a 73% reduction, respectively. So for a very low cost, we can be saving millions of lives a year, including many of the 13 million sepsis deaths. That should be a very high priority to address. So ACON has identified 5 medium-term priorities, and all of them will help improve sepsis care. First of all, it's to strengthen acute care services by expanding implementation of the WHO acute care resources, and the basic emergency care that we'll hear more about from Joe afterwards is a key priority to scale up. It's also to empower the communities and to implement the new community first aid responder program and also study care-seeking behavior. It's about enhancing access, improving quality by clinical quality improvement, and also working on assessment and planning at both system, pathway, and facility level. So that was a very brief introduction to the Acute Care Action Network. There's been quite a lot happening since the establishment in 2023. As mentioned, already 50 organizations have joined, and there is a lot of momentum now in the group. So please, for anyone interested, check out the website for more info on the WHO website. And with that, I'll hand over to Joe Bonney, who will go through in more depth around the basic emergency care program, which is one of ACON's key initiatives. Thank you.
Thank you very much, Ingrid, and thank you for really powerfully and showing the importance that this is integrating systems, and the downstream benefits are enormous. So investing in emergency, critical, and operative care is not only is going to save people's lives, but it's also smart economics. It's a wise investment, and it really is foundational to any strong, effective health systems. And thanks also for bringing up the neglected point about the rise of non-communicable diseases that are responsible for more than 70% of deaths worldwide. For those who think it's a non-surgical, non-critical, non-operative challenges, that's completely not the case. And you show that clearly, that if we're going to address the tsunami of non-communicable diseases that are affecting every country in the world, even more so low and middle income countries, we have to have a strong emergency, critical, and operative care system. So thank you for doing that. To hand over to Dr. Joe Bonney. Joe, the floor is yours. Thank you for being here.
So thank you very much, and I'm very happy to be here with you all today, presenting at the 5th World Sepsis Congress. It has been a lot of really interesting talks the whole day. It's been super engaging, listening to all the conversations and looking at how it all dovetails into the fact that we need to have practical way to say that we have been able to tackle at least some parts of sepsis. And I would look at the scaling up of the basic emergency care course for timely resuscitation of patients with sepsis. I have a lot of affiliations, but no conflict of interest. So picking this from the African Sepsis Alliance, it's clear that we have a lot of sepsis deaths occurring in the African region. And really, the true burden of the sepsis death is really not well known because there's very little testing, little diagnosis, people that do not present to the hospital. And so actual burden of sepsis and the financial burden is really not known. But even if this is what we're seeing, then it really brings a point that we need a solution to this. Some work that was done in Ghana, looking at the pathway of care with Dr. Tegan Lucas, looked at the timing of when people had an infection. Because if we do tackle it at an infection point, then we would not hit to the sepsis. It's true that quite a significant amount of people looked at initiating some form of care at home on the first day. If we did encourage these people to make that a hospital visit, I am sure we will be able to reduce that burden. But even with that, we noticed that among those that presented to the hospital, 62 of them came straight to a hospital, which was our research facilities, which had the potential of being able to manage infections and that's sepsis, meaning that we do have a chance to be able to fix this. This is a diagram that is well known as the emergency care systems framework, and this is really common. But on the ground, this is what we actually have. People leave their home to the church, to the pharmacy, to one healthcare system, goes back home when they don't trust the system. They're getting to these places in private cars, at the back of motorcycles, and so on. So being able to have a capacity building approach, which will train people at all cadres to be able to recognize and manage sepsis is really critical. And this is where the basic emergency care course comes into play. The basic emergency care course was developed by the International Committee of the Red Cross in partnership with the WHO and has been moving on with its accreditation with the International Federation for Emergency Medicine along its partners and has been implemented now in over 60 countries. Its wide implementation and its aim of being able to standardize the approach of recognizing and management of emergency conditions, with sepsis being quite a big burden among all of this, and looking at the key treatments and procedures for life-threatening conditions gives us an approach that basic emergency care course singles itself out to be able to manage this. If you look at how it is developed and its models, you can see that it targets the basic principles of emergency care: airway, breathing, circulation, disability, and exposure. All of these are critical components that will point you in the direction of this patient is not doing very well. Could it be sepsis? But even if you look at the breakdown of the systems in which it manages, trauma seems to be up there. And someone would say that trauma is really not sepsis. Difficulty in breathing, altered mental status, and shock are really clear presentations of sepsis. But patients in trauma will do much better. They do not get into sepsis, or if a septic patient or the trauma leads to sepsis, we would need to be able to manage that. And the initial care of the trauma will probably decrease the chances of sepsis being a complication to that trauma. BEC is for everyone. The basic emergency care course is for the whole emergency team. So we're looking at students, nurses, ambulance providers. And as simple as it is, as Ingrid said, it is a simple course that people can take, people can scale up, people can use. But what are the challenges that we're having now in being able to scale up this? The lack of training equipment, taking time out of practice, and then the knowledge transfer and sustainability. So with this, I will go through a few of the points here to look at how we're able to look at this. So scaling BEC with the African Federation for Emergency Medicine, our story. So the African Federation for Emergency Medicine, it's adapting the system that has been used by the International Federation, where you will sit in a course for 5 days. You become a provider, meaning that you can provide care for somebody who needs care as a BEC person. If you do pass trainer of trainers, you become a provisional facilitator. And then after you've taught under the supervision of a master trainer or a master supervisor, you become a registered facilitator. And after teaching 2 more BEC courses, you yourself will graduate as a master facilitator. This is what the numbers look like for the number of courses that have been run across the African continent. We have not been taking it easier at all. Over the years, we have tried to run as many courses in the African region, and the certification and the quality control has been maintained by ensuring that the proper trainers, the proper ratios have been adhered to. If you look at the numbers from 2015 all the way to 2024, you can see how in 2021, this really shot up. And we can all understand after the COVID, the need for emergency care training could clearly be seen. And we're happy to show that among the people that are trained, the nurses build up as more than half of the population that have been trained. This is really critical because in low and middle income countries, and in most places, you do have more nurses than you will have doctors and other healthcare workers. And they, in the sense of being able to recognize severe critical conditions, including sepsis, gives us a better chance. If we look at how the BEC or BEC faculty has been scaling up, we can realize that we're training more master trainers, we're training more provisional trainers, and these will help cascade the training in various countries. As of now, we have over 8,400 people who are BEC providers scattered around the African continent and with various other degrees up to the master trainer level. This shows an image of what basic emergency care course looks like. Entertaining, fun, very, very, very educative, and it keeps people on their toes for the duration that they spend there. Doing more for all and for sepsis. When we look at taking people's time away from work, now the basic emergency care course is moving into a hybrid session where you can have a lot of the lectures online and only 2 days of practical skill stations. And this will help shorten the time it takes people away from their workplaces and giving them enough of the skills to be able to move forward. And this comes in all the models of interactive lectures, case discussions, skill stations, and practical case scenarios. And we're looking for this being scaled up greatly. Last but not the least, when we talk about the lack of training equipment, I'm really grateful to Laerdal for looking at developing an emergency care learning lab. This learning lab allows us to be able to pick up a bag and move to train for BEC and captures all the components you need for a BEC learning. And it's part of the 25-25 campaign by the WHO to train as many nurses in 25 countries by the end of 2025. You can see here that it's gone through multiple iterations and collaborative efforts to be able to build it to the level that we have and has been distributed in many countries across the world. With 90% cost reduction, this is definitely a game changer for scaling up basic emergency care and extensive testing across the fields where this will be used. And lots of testimonies, especially from people around the continent who have used this, saying that it's really engaging and helps with the practical sessions. This is a training session that happened in Botswana as part of the African Congress for Emergency Medicine, where we had a post-conference workshop and trained trainers to be able to move out and train with everybody receiving a bag of this portable toolkit. Aside basic emergency care course, and it will be not right to mention this, there are a host of other emergency care toolkits that are in development now, and these ones are already available on the WHO website. So you can find these available and then also keep your eyes peeled for ones that continue to be developed. I bring this back to show that we have over 8,000 providers trained in the basic emergency care course who will have the knowledge and skill to recognize and manage sepsis at least at its primary level, and will have the training to be able to hand off when they need to. With this, we're hoping that this slide can have sepsis removed and provide better care for all as we scale up basic emergency care course to tackle sepsis. Thank you very much.
Joe, thank you very much. Superb job and sharing really life-saving training programs that the WHO has, particularly the Basic Emergency Critical Care course. And congratulations to you and all of your colleagues who, obviously looking at the map of the continent of Africa, what you have done to share that widely, what you've done is obviously saving a lot of lives around the continent. And we hope other parts of the world, well, we're committed having other parts of the world on this call to learn from you, and that good news, those programs can be shared widely, which, as you said, they're all on the WHO website, so please take a look at them. And with that, it's wonderful to hand it over to Dr. Carolina Haylock-Loor. Dr. Haylock-Loor, wonderful to see you. Please, the floor is yours from the World Federation of Societies of Anesthesiologists. Thanks, Carolina, for being here. Over to you.
Thank you very much for the opportunity. I'm grateful with the organizers for this opportunity to participate in the 5th World Sepsis Congress with this topic of ERAs, enhanced recovery after surgery and for optimizing sepsis outcomes. I'm Carolina Haylock-Loor, as you said. Thanks for the kind introduction. I'm an anesthesiologist, critical care specialist, an interventional pain physician. I'm based in Honduras, a low and middle income country. I'm currently serving as president-elect of the World Federation of Societies of Anesthesiologists, WFSA. No conflicts to declare related to this lecture, but today we will briefly explore perioperative sepsis and provide overview to ERAs. We will discuss its importance, impact, and opportunities, challenges associated with the implementation. The whole day, I think you have heard about sepsis definition, but when it's around surgery, that's the life-threatening acute organ dysfunction due to infection around surgery, it's perioperative sepsis. And each year, of course, we have a lot, over 19 million people affected by sepsis, while in hospital mortality it has been reduced from 2000 from 35% to 18%. Many survivors, as we heard Krista at the beginning, face significant long-term impairments, with 1/3 experiencing complication within the following year. Postoperative sepsis is defined as a very rare condition and affects up to 1% of patients who have routine operations. But when we go to emergency, when we go to low resource settings, those numbers, of course, can change. The numbers are different for healthcare-associated infections after surgery. The prevalence of healthcare-associated infections after surgery ranges from 4.6 to 9.3, with surgical site infections after surgery being the most common. In advanced country, 7 out of every 100 hospitalized patients acquire healthcare-associated infection, and the financial burden of these infections is substantial, with estimates suggesting that surgical site infections can prolong hospital stay by an average of 9.7 days, and the cost of it's over $20,000 per admission. So the financial burden of these infections is substantial. So the importance, ERAS programs are crucial for incorporating evidence-based practice that minimize perioperative stress, gut dysfunction, and iatrogenic infections while promoting early mobilization and recovery. These multimodal care pathway in the pre-op and intraoperative and post-operative have shown benefits, such as decreased complication rates, accelerated recovery, and particularly in colorectal surgery patients. Some other evidence, for example, in 2017, publication from the Canadian ERAS group highlighted that post-operative ERAS intervention significantly improve recovery outcomes across multiple hospitals, reducing complications and promoting early discharge, not only for open surgeries, but also for laparoscopic procedures. A systematic review from Johns Hopkins in 2018 concluded that ERAS protocols are effective tools for preventing healthcare-associated infections. This study found significant reduction in postoperative lung infection, urinary tract infections, and surgical site infection, emphasizing the need for transdisciplinary programs to enhance surgical care. But is this evidence only in high-income countries? We can see the Pakistan experience published last year, in which the ERAS group reported a reduction in postoperative complication, with only 7.5% of patient experiencing mild issues compared to 14.5% in a standard case. So it was reduced by half. This highlights the potential ERAS protocols to improve patient recovery and reduce healthcare strain, especially in resource-limited settings. A recent study involving nearly 9,000 cases demonstrated that ERAS implementation led to significant reductions in various complications. It decreased hospital stay from 5 to 4 days, and a 35% of reduction in the odds of 30 days complication, supporting broader ERAS adoption to enhance patient care and reduce cost. Another study published last year concluded that ERAS protocols significantly reduced wound infections and postoperative complication in orthopedic surgery patients, further validating the effectiveness of these programs. But what about ERAS in emergency cases? Research from Italy published in 2023 demonstrated that implementing ERAS protocol in emergency general gastrointestinal surgery is feasible and safe, with manageable complication rates and effective postoperative care strategies. So the ERAS program includes pre-op strategies like patient optimization, antibiotic prophylaxis, nutritional support, but also in the intraoperative management, focusing on anesthesia techniques, going more for regional anesthesia and fluid and temperature management, and also postoperative care, emphasizing early mobilization, rehabilitation, pain control, and nutrition intake. All these components work together to enhance recovery and reduce complication. Despite its benefits, implementing ERAS can be challenging. Barriers include resistance to change, cultural aspects, and lack of resources, diverse patient needs, lack of data and monitoring, and the need for multidisciplinary collaboration. Education and training are crucial to overcoming these obstacles and ensuring successful adoption. But also with challenges always come opportunities. So opportunities for improving ERAS implementation, including leveraging technology for better data collection and analysis, fostering a culture of continuous improvement, and tailoring protocols to specific patient population and healthcare settings. So in conclusion, ERAS protocols offer a promising approach to optimizing sepsis outcomes in the perioperative setting by reducing complications and enhancing recovery. ERAS can improve patient outcomes and reduce healthcare costs. So continuous research and collaboration are essential to expanding its adoption and effectiveness. Last but not least, part of this topic will be highlight in our World Congress. So I invite you to join us for the World Congress of Anesthesiologists in Marrakech 2026, April 15 to 19. And I thank you for your attention. I look forward to any question or discussion we may have. Together, of course, we can work towards better outcome for patients with perioperative sepsis through the implementation of the ERAS protocols. Thank you very much.
Caroline, that was outstanding, and it's just wonderful to have an anesthesiologist here amongst us. We know amongst all of us and on the session that anesthesiologists are actually vital and essential to addressing sepsis and are a cornerstone of health, of an effective health system. So really, thank you for sharing the ERAS system with all of the folks here and showing the benefits of actually having a broader uptake of ERAS protocols in reducing mortality, morbidity for patients across a wide range of challenges. So with that, we have a few minutes left to go to questions, and I'll toss this over to everybody as an omnibus question. I'm going to give everybody a chance to give their 1-minute highlight at the end, and we'll go in the reverse order. But I'm going to start obviously with you, Krista, going from the order in which we started. So I'd like you all just to share with the audience, what are the 1 or 2 top action items that individuals who are listening to this can actually take away and implement, and be able to translate what they've learned on the sessions during the Congress to be able to implement to reduce sepsis and reduce morbidity and mortality. Krista, I'll turn it over to you, then we'll go to Tsion, Ingrid, Joe, and Carolina. Krista, please, over to you. 1 or 2.
I think being very alert. Everyone should be very alert. Healthcare professionals, but also everybody in every community, in every situation, and don't think it can't happen to you. It can always happen to you, and it usually starts very small. A small wound, or sometimes you can see it. In my situation, you couldn't see the wound, but it was invasive. But sometimes a small wound when working in a garden, for instance, can lead to extreme situations. So be very alert. If your skin gets a bit red and gets swollen, immediately go to the doctor because something isn't right.
Thank you, Krista. Isn't that the case? And you powerfully explained it. Otherwise, a completely healthy woman going from completely healthy to being critically ill in a very short period of time. And that's an enormously powerful takeaway message. Tsion, over to you. 1 or 2 big takeaways for the audience of what they can do to implement what they've learned.
Okay, so thank you very much. So I would say really part of my presentation was using the tools that we have for advocacy, right? You're like, oh, I need more research, I need more data, but really to advocate for what you believe in, that the timeliness, all these resources that we have to push it into implementation and whatever you work, and to do it unapologetically, right? You are the caretaker, you know what works, what also Krista talked about, right? Really be able to advocate for, you know what works, you have the evidence, you have the tools for it, and advocate for your patients when they first walk into your site, wherever they are, and use the tools to advocate for that. And really, as we know, timeliness is a big component of that, and really push that sense of urgency, which lacks in many places across the world.
Thank you very much, Tsion. Ingrid, please, over to you.
That's a big question, and I think there are many different people listening to this. But I think overall, from my perspective, it's there is a need for a full chain of survival and a strong acute care system that goes all the way from community through the ambulance EMS systems into the hospital. So no matter where you work in that system, if you can do anything about sepsis, there are tools that are cost effective and that will work. and be very curious about how you can really link with the rest of the system and work together to create a strong, cohesive system.
Just to follow up, or yourself or anybody showing the value proposition to policymakers, dollar in or dollar out. Has anybody got that? Anybody on the panel? If not, that's something we need to do. Fantastic. Joe, I'll go to you, but there's another question for you specifically, Joe. Thank you, Ingrid, very much. Joe, there's a question also for you beyond this is what's the place of the EECC course when there's the basic emergency care course? The question from the audience is, are we not reinventing the wheel? Do you have a response to that along with the other question that I asked?
Great. Thank you very much. I will start with the EECC course. So we're not saying that the basic emergency care course is the only way to train people to be able to manage patients. We have been able to demonstrate that the basic emergency care course, within its limited capacity of being able to train people to the point where any healthcare worker can take this course and apply this course immediately to be able to save lives, is quite phenomenal. So the essential emergency and critical care course also has its place, but these cascading of this along the line is what makes a difference. This is being cascaded along the line of emergency medicine societies and other related societies in the ECHO framework. And these other courses can be cascaded alongside in a synergistic approach. There is no reinventing or territory approach across this. We can speak very clearly for BEC, and we will be glad to hear a lot more about the EECC course. In the sense of the question that you asked the rest of the panel, I think the key here is adaptation. All the tools that will be available in one country to the other will need to really be looked at on how it can be adapted for maximum effect. Irrespective of where you live, there's obviously some well-resourced places in one part of the world and low-resource areas. As these tools come out, how we can adapt to those tools to make sure that they are essentially placed and to be able to get the best benefit from this. Back to you, Keith.
Great. Thank you very much, Joe. Much appreciated. And now to you, Carolina, those questions I asked, but I'm going to add a little supplement to you. I want to ask you, how do we get more anesthesiologists involved in our effort? Because honestly, in this role here at the Consortium of Universities for Global Health, we've been trying to get anesthesiologists involved, right? Joe, we get surgeons involved. I'm saying, okay, this is good, but the best surgeon in the world really can't do a lot of their work without proper anesthesia. So how do we get more of your colleagues involved in our space?
Yes, thank you very much. I think this initiative is an example of what we can do. And it's, as WFSA, of course, we with all this eco-resolution and the ACAN network has been key for getting to our member society. So as World Federation of Societies of Anesthesiologists, we are doing our part, of this eco-resolution. And I can in summary, I can say 3 words that we use frequently because it's part of our key strategic words, and that is advocate, as Dr. Tsion said, collaborate, collaborative efforts, for what we're aiming for, and also education and training. So I will make like a summary with those 3 words, and you must know that we are doing our part on this on these efforts, and anesthesiologists and our member societies are aware that we are going that pathway.
Thank you very much, Carolina. So you didn't ask me to do this, but I invite all non-anesthesiologists to come to your anesthesia conference because we have to cross-pollinate, right? And I'm going to do a shameless plug for our organization, the Consortium of Universities for Global Health. We have nearly 40,000 global health practitioners worldwide, over 200 institutions. Our next conference, your conference, Carolina, next year is going to be in Marrakesh in April. Ours will also be in April 9th to the 12th in Washington, D.C. There's a few things happening here, as you may know. So please come to our conference next year and then go to Marrakesh, right, Carolina? So we can actually keep the momentum going. So I'm going to turn it over, go in reverse order for any last points everybody wants to make before we bid everybody adieu. So Carolina, I'm going to start with you, and then we're going to go to Joe, Ingrid, Tsion, Krista, and then I'll just thank all of you. So please, Carolina.
Yes, thank you very much. Yes, I would like to say, because sometimes we don't know, as some of us mentioned before, how to go to policymakers and try to lobby or convince them what we're doing, what the work we want to, or the aims or the goals we want to achieve. And so this collaborative effort that I mentioned before, and all these strategies about, for example, establishing robust data collection system are essential, because they will give evidence, and then the evidence we can go with those to our policymakers. And this long-term benefits of ERA's protocol, that we are aware that it including reduced complication, shorter hospital stays, lower admission rates, lead to significant cost saving. All of these arguments, all of these evidence-based arguments can make administrators, policymakers, governments, to get on this global alliance, like for fighting sepsis and fighting all these type of infections. So, and we are all actors in this, and we are all have a responsibility in this. I thank you. Hand over.
Thank you, Carolina. And if I can say, as a former policymaker, as a member of Parliament in Canada, I would encourage all of you who are online, as you've heard from all of our powerful speakers, you can speak truth to power, because nothing is more powerful than the patients, as Krista shared with us her experiences, but also all of us who've actually had to deal with patients in the emergency department, in the OR, in the field. You can speak truth to power because your policymakers generally don't have that experience. So they need to hear from you. Tell your stories. Stories move people. Data generally doesn't. So not only appeal to the coconut, but also importantly to the heart. So please do. So with that, Carolina started a sharing of conferences, which is wonderful, Carolina. And Joe, you have something to share. So please, over to you.
Definitely. I'd like to invite all of you to the African Conference for Emergency Medicine happening in 2026. You can't tell me I did not tell you this early enough. And it's happening in Zanzibar. So you can come for the conference and then the vacation. So you're all invited to join us for that. My final words are, I think the little steps will always make the difference as long as we remain consistent. So we do need to have the policies in place, but we need to be able to translate these policies into simple, actionable guidelines at the bedside of patients. Early diagnosis, recognition, early treatment, and above all, the training of healthcare providers and capacity building to be able to recognize and manage emergency conditions, especially sepsis. Thank you very much.
Thank you, Joe. And I think you've given a powerful note. Anybody can implement at a community level. Small steps can make a big difference. So thank you so much for sharing that. And I hope lots of anesthesiologists come to the African Conference for Emergency Medicine, right? Wonderful. Ingrid, please, over to you.
Yeah, I'll echo what Joe said about everyone has a role to play in this puzzle or this chain of survival. So think about where you are and where you can make a difference, and seek out the partners who can help make it happen. There is a need to strengthen every step of the chain of survival, and in particular in the communities. And also just thank you to the Sepsis Alliance who's arranging this fantastic day. And it's been amazing to hear all these different perspectives.
Thank you very much, Ingrid, and thank you for all your support for this effort. And don't forget to take a look at the Laerdal Global Health. You can take a look at their amazing work online. Next, Tsion, please, over to you.
Thank you. It's very hard to follow all the great things that has been said. So I'm really going to talk about maybe things I did not mention, and I think it's the reality of our world right now. It is a difficult time for global health. it is a difficult time to be in healthcare, to be in research, to be in science. But I think conferences like this remind us why we do what we do, right? Is to advocate for the science, is to advocate for the evidence, and really what Dr. Keith Martin said, right? It is important that we keep on pushing, informing, speaking truth to power. And also when you have evidence to prove that, is amazing. So I really, encourage everyone. I tell many of my mentees that if we don't keep on pushing, if we just give up, it's just going to be worse for the generation after. It's going to be worse for all of us. And I do believe things will change, but it is if we continue to advocate, speak up, and really be, the voice and the light, especially for the voiceless around the world. So I encourage everyone to really take on what you learned today and to push science forward in every way that you can.
Tsion, thank you very much. And as you said, in these difficult times, that difficult times also have opportunities, and we can't give up. Thank you very much for sharing that powerful note. And Krista, you have the last word, please.
Thank you very much. First of all, I would love to invite everyone to a big sepsis conference that we're organizing in Brussels on September the 9th. It's called United Against Sepsis. It's for patients and professionals. It will be organized by the European Society of Intensive Care Medicine, by Sepsis Stronger Together, which is actually a consortium of sepsis patient organizations from the European Union. And also by Sepsibel, which is the Belgian sepsis patient organization. You can either come in person to Brussels or follow the conference online, and we would be very happy to have you joining us. And if I may so conclude with a message to healthcare professionals, I'm convinced that patients are experts too. Nobody knows his body as well as the patient himself does. So please use this experience. If the patient says he feels like he's going to die, he's really in an awful state. We fight the same cause, so why don't we speak with one voice? Thank you very much.
Krista, thank you very much. You having the last word, coming from your lived experience, really is the most powerful message anyone, I think, could hear who's listening today. So just in closing, I'd like to thank everybody in the audience for being here today. I hope you will tune in tomorrow, because the Congress is a 2-day event on the 8th and 9th of April. So please tune in tomorrow. And on behalf of all of us here, I would like to thank our outstanding speakers today, Krista Bracke, Dr. Tsion Firew, Ingrid Laerdal, Dr. Joe Bonney, and Dr. Carolina Haylock-Loor, for really sharing your powerful expertise with all of us, giving everybody very specific things they can do, which is important, and really challenging us to get behind this neglected challenge and sharing with everybody that there's a lot we can do. I'd also like to thank the wonderful people who've helped to put this on, Simone Mancini, Marvin Zick, and their teams, who have really, this wouldn't happen without them, and it's an enormous lift to be able to pull something like this off. So from all of us at the team, the GSA, thank you very much for enabling all of us to contribute to this effort. And again, if you're near a Sepsis Alliance, if there's one near you, please join it, because we're stronger together. Thank you, everybody, for joining us today. Keep well, take care, and we will keep moving onward. Bye for now.